So now, hopefully, if you guys have any questions, feel free to ask them. I'm more than happy to answer them. There's a mic here, right here.
There's one right up the front here.
Yeah.
Just a quick question for Eric. So, do you have anything that you wish someone told you before surgery that you didn't know until afterwards?
Yeah, it's not going to be as bad as what you think. I think that was the thing for me. I didn't know what the surgery would entail until I started seeing, people on YouTube making videos and kind of sharing their stories, and I thought, wow, that's quite a bit different from what I expected. Like I literally thought I was going to just be at home managing the bag, and that's all I would be doing. And I kind of wonder what my surgeon must have thought when I came in with some of these questions, because they were, as far as I'm concerned, they were kind of ridiculous, but I had to ask them because I didn't know better. And now that I look back at it, yeah, they're funny, but they helped me to move forward. Having that reassurance that, yeah, you know what? Of course you're going to be able to drive. Why is that a problem? Of course you're going to be able to go walk around the block. That was actually a question I asked. Will I be able to walk around the block? And I ended up walking 5 kilometers a month after surgery as part of my anniversary. So, things change. Yeah.
Dr. Suri, this is for you. I'm an ostomy visitor and for patients. And what really distresses me is when I go into a patient's room at their request of the ET, as I explain that I'm there they've agreed to see me. And I mentioned the ET's name and the fact that I had the same type of surgery. The first thing they're saying to me now, I'm going to have a reversal. That's all they're concentrating now on. And I'm concerned that the surgeons are giving the patients false hope.
Right.
And I understand that under drugs and anesthesia, they're not listening, they're only hearing reversal probably. But I do know that some of the patients have gone for reversals and it failed. And those people are depressed and devastated. And it's a big concern for us.
No, I agree with you. I think that's also important how we word things to patients, right? So I can't speak for other surgeons, but when I see a patient in my office and there is an issue of an ileostomy or colostomy being created, like I said, their first question will be, is it permanent? In some cases it will be, so then I say yes, and then I'll counsel them through that. But if there's a possibility that it's going to be reversible, I will say there's a possibility of reversing, but not always. So I usually make that pretty clear to them. But I do think part of that, if you're seeing them in the immediate post-operative period, number one, there's anesthetic on board. They might be a little bit confused, but also, they're really hoping for that reversal because they haven't lived with a stoma, right? And they don't know what life is like with a stoma, so they just want to hold on to that as being the best possible solution for them. But I do try to emphasize to all patients is, especially if I'm dealing with a cancer, is, there's 2 goals when I'm treating them. So number 1 is to cure their cancer, right? And the second is to restore the continuity of their GI tract. So, most patients would agree that that first goal is the most important, right? So that they can live a life that's healthy and disease-free 5-10 years from now. The continuity of the GI tract, I don't try to minimize that, but I do tell them that life with a stoma will be okay long-term. So I think it's very important how you word it to patients, how much time you spend with them. But absolutely, I think that sometimes patients do hold on to that reversibility a little bit more than they should.
Yeah, and they put their life on hold.
Absolutely.
Not living after that.
Absolutely. And so that was the second question that they always ask me, at their 2-month visit, 6-week visit, 3-month visit, 6-month, they say, when am I going to be reversed? I'm ready, whenever you are. And I say, well, like I said, the longer we wait, the more successful it is going to be. That's one thing I tell them. I also tell them, if they're going through cancer, they have to complete their chemotherapy or whatever other adjuncts to therapy they have, like radiation, and get through that first. Number 3, try living with your stoma for a little bit, because it may not be as bad as you think. And also, number 4 is that, even when we reverse the ileostomy or a colostomy, sometimes it doesn't work. And, you're going to be in hospital if it fails for, about a month, 6 weeks if there's a complication. So I think it's important to enjoy time, that they have away from the hospital, because they've been through usually a major operation within the last year, right?
Thank you very much.
The thing that's really important too is having that visitor to look normal. You can do things that are normal, and that visitor will help to instill that hope that they can do all the things they did before, regardless of how long they have to have that ostomy for. And I think we're pretty consistent with Dr. Suri in that, you got to wait, you got to talk to the surgeon, and you have to make sure things are healed and everything's working well. And I think we don't try to encourage people to have their reversals soon, because we know there can be complications, that the longer you wait, or living with the ostomy is just not that bad. Now, of course, I always say, I don't have an ostomy, so I can't tell you, but I can definitely connect you with somebody who does know.
I just came to fix the mic, but I didn't want to run away without I'll ask a question. So I've had my ostomy for a lot of years, and I had it when I was 25 years old. So I think, after you get over feeling like you're sick for a long time, then you start feeling healthy. One of the questions that comes to mind is like what about my sex life? Some people are married, some people are single. And I know that doesn't have a definitive answer, but I don't know if people ask you, Sheryl, what that's going to be like, or Dr. Suri. Eric, I know you must be getting lots of questions about that, so I'll just leave that open for a bit of discussion.
I'm
Do you
supposed to
want
go
to
first.
start? You go ahead. You start. No, I can start. We sort of find that we have to read our audience, right? Of course, everybody needs to be intimate, and how you become intimate is whatever your choice is. But there are many ways to talk about it, but it's important to know that after your surgery, there could be some complications from the type of surgery you had that you need to discuss with your surgeon. But at the same time, there are things that you can do without having intercourse, or without whatever you do, I don't know. But there are many ways of being intimate. But also, if you have an ostomy appliance, there's many ways to make it pretty, or make it not appealing, but make it so that it's not even part of the picture, right? And so there are many different accessories you can wear. There are many different products out there that are pretty nice to wear. And pretty, you'd never think of being pretty wearing an appliance maybe full of pee or poop, right? But you have to ask your surgeon about, or your doctor about, what is life going to be? How am I going to satisfy my husband or my wife with this appliance, right? And but it's kind of a difficult thing to ask people. It's a difficult thing to bring up. But we have to be aware that no matter what age you are, there's some form of intimacy that you need to enjoy, because that is part of your life, right? And if you are single, it's not necessarily, you need to still meet people and enjoy people. And if they like you for who you are, they're not going to care about what's on underneath your clothing. You'll learn to adapt, just like you do with everything else.
Sure. So I think that a big part of it is adaptability too, right? So adjusting to life with the stoma. So that takes time in terms of what you can eat, what you can do, and even the sexual concerns that we're talking about. I will say that I find it very interesting that if you look at patients who've had what's called a low anterior resection. So do you want to show me your...
Oh, I'd love to, yes. Okay, let's put that small intestine back together.
Yes.
Okay.
All right, so a low anterior section means that you're taking out usually this portion of the bowel. So you're hooking up, the descending colon right to the anus or upper rectum here. That's probably the most technically challenging operation that we do. So there's a few things with that operation. So there's a risk of autonomic nerve injury. So the autonomic nerves are the ones that control sexual function and urinary function. So those can get injured during the operation. They can also be injured by the preoperative radiation that patients receive. The risk of that is about 1 to 2% these days in comparison with about 25% that it used to be, because our dissection techniques are a lot more meticulous. So that's one way the nerves can get injured and affect sexual function. But what I find interesting about this operation is that so patients who have a low anterior section, they will be hooked up again. And they may have a temporary ileostomy that we reverse. In comparison with patients who have a colostomy, meaning all of this is resected for whatever reason, and they have an encolostomy with no chance of reversal. If you look at the quality of life studies, meaning patients' psychological well-being, sexual well-being, physical well-being at a year, it actually is equal, if not better, in patients who have an encolostomy in comparison with patients who have been reconnected. And part of that is because if you take out this portion of the colon, I was going to say the low anterior section.
Oh, sorry. Okay, I was getting a little ahead. Sorry. Yeah, well, we'll just put it back together. Is it backwards? Oh, sorry. I'm doing this upside down. See, that's why I just teach people about it. I don't actually do the surgery.
So you're going to lose that rectal reservoir, right? So, and basically the stool often will pass right through to the anus very quickly, and you won't have very good control of your bowel movement. So patients, like me as a surgeon, for example, if I were to have a choice between having an encolostomy or low anterior section, I probably would choose having an encolostomy, because if I'm doing an 8-hour operation, I can't be running to the bathroom 10 to 12 times in 8 hours, or having an incontinence episode, which often patients will get with their low anterior section. With the colostomy, you're better able to control your output and time the emptying of that bag. So when we're talking
appliance or pouch.
Right.
Yeah. Okay.
He likes bag.
This is a whole new discussion. Yeah.
So I guess what I'm trying to say is that when we talk about the sexual issues that are raised with having a stoma, sometimes they may not be as bad as we might initially think. Having a low anterior section, if you're having nighttime incontinence or frequent bowel movements, that may be actually worse, even for things like sexual activity.
Yeah.
But you need to probably wait until, we always tell people, you need to wait until at least 8 weeks until you're going to talk to your surgeon, and he's going to tell you whether or not it's time to resume, intercourse or any intimacy.
Yeah, intimacy is actually a topic that I've covered, and I actually had a couple of friends, female friends, that were talking about their experience with having an ostomy. And so there's a lot of practical things that you can do for yourself. So, making sure that your appliance is totally empty before you engage in anything. There are accessories that you can wear that will either conceal and or support your appliance so that movement and friction aren't so much of a concern. There are also, smaller size pouches that you can wear, even just temporarily. That might also help. So there's a lot of practical things that you can do. But I think the most important thing, just talking to other patients about this, is that you have to show a level of confidence to kind of set a bar for your partner. Because if they see that you're intimidated by your appliance, or you're not showing a very high level of confidence, it kind of mirrors back on them, and then they're not going to be too sure about how to approach this. So I think if you're comfortable with your appliance, you're comfortable with managing your ostomy, you're going to kind of elevate the experience, and then you can both just enjoy yourselves without having the appliance get in the way or be, a burden, because it shouldn't be. And from the people that I've spoken to, it hasn't changed their sex life really at all. If anything, I think some of them appreciate having another chance at life, and it's empowered them to have an even better sex life than they could have imagined. So,
Thanks for the question, Deb. Hot topic, yeah.
Go ahead. Question for Dr. Suri.
Sure.
When you see the small intestine and the large intestine, and then when you do the colorectal surgery, you remove that whole large intestine. I've always wondered, how does your body and the other organs adjust to having that large organ gone? Like, how do they all shake down? Does it all go back here?
Well, the large bowel actually doesn't take up that much space in the abdominal cavity, believe it or not. It's actually fixed posteriorly, or to the back almost, on the sides. The transverse colon does swing down a little bit, right? But actually, when you remove it, you have all of your small bowel left, right? And that small bowel kind of just finds its way into all those other corners, and basically your body will adapt to that.
A question that I get is, when you have your colon removed, does it feel empty kind of inside? And it doesn't. I never noticed it anyway, even though I tried kind of observing. One thing I did notice, though, and I don't know if any of you are missing a colon, I want you to remember if you felt butterflies in your stomach after having your colon removed, because I haven't. And this is something that I've asked other ileostomates, and they've thought, yeah, no, I don't remember having butterflies in my stomach after surgery. So that's one really cool, interesting fact. And hey, maybe it's true, I don't know, but that's something that I've observed. So.
I thought it was
Someone else?
Okay, this is kind of for all three of you. Eric, would you, if you were given the opportunity, would you have a reversal done?
So that's actually a good question. For some people who have inflammatory bowel disease, if they have ulcerative colitis, reversal is often an option. In my particular case of Crohn's disease, everything was garbage. I wouldn't have an opportunity to reverse it, and just because of the type of Crohn's, it would probably be at a very high risk that something would happen. Now, if I were given the opportunity to reverse it, would I? Knowing that my life is the way it is right now, having an ostomy, I wouldn't want to risk losing that. And I think for some people who make the decision from a temporary to finally go permanent, even when they have the option of reversal, they say the same thing. There are risks to having a reversal, and some people are just in such a good place with their ostomy that they don't want to lose that. So I personally wouldn't.
I'm an ostomate, a urostomy, but I'm also a visitor, and I also work at a supply store where I have talked to several people with ostomies, or ostomates, whatever you want to call them. Trudeau's not here, so we can call him whatever. Anyway, what do we encourage them to talk to people that have had reversal, people that, like, the life you had before, do you want to go back to it? No, I wouldn't. But do we encourage them to look at that?
Well, through our department, we have, if there's questions as far as how things are going to function, should I go and have a reversal, we try to connect people with someone who's had a reversal. We have volunteers, people that are still members of the Regina Ostomy chapter who have had reversals, who, whatever their experiences are, have good experiences, and then some that try to go through reversals that don't. I think it's important to talk to someone who's been and had a reversal before. I mean, if it's really something you need to do that. But if you are sort of on the edge, I don't know, you got to go with your gut, no pun intended, but you got to go with what you think is really
I don't
you
know
need.
how often you as ETs in Regina see your patients, but your supply stores see them a lot sooner, a lot more often than you guys do. So we can kind of see them going through a lot of problems.
Yeah.
And we say, go see your ET, go see your doctor, whomever.
Yeah.
But we're trying to encourage them one way or another. And it's hard sometimes.
We're very fortunate to have a very structured program. We see our patients a lot. We see our patients 2 weeks after they leave the hospital. We also see them at 8 weeks. We will see them between 2 weeks and 8 weeks, whatever that patient needs. Ostomy, we prioritize what our patients need. We will see people at 1 year. Our office manager, Patty, sends out a letter inviting people to come within the year. But really, you're welcome to make an appointment for whatever you need between 8 weeks and 1 year, or 1 year and to infinity. Whatever you need, it is our goal to try and help out and support you in how you need. And that it's really important because people have anywhere to go, right?
You guys are lucky. That's all I can say.
Can I just add something to that?
Yeah.
So, when you're saying that patients, should they or should they not be reversed, I think that was kind of the basis of the question. I think it's, first and foremost, I think you have to respect the patient's autonomy, right? So everyone's going to be a little bit different in terms of their values and their goals. But I do think giving them some time with that ostomy is important. And I think it's also very important to inform them that the reversal is not as easy as sometimes people think, right? So if you are reconnecting the large intestine to the rectum, that is a very risky operation in and of itself. And the risk usually is because of a blood supply issue, because it's very hard to reattach large intestine together because the blood supply is so precarious. Small intestine, to reverse an ileostomy, people think that's easy, but it's actually not that easy. You actually still have to reconnect the two ends of the small intestine together, and there's a leak rate. Even in the best of hands, that leak rate will be 5 to 10%. If you have something like inflammatory bowel disease, that leak rate goes up to about 20 to 30%. So it's okay to be reversed, but patients need to understand that reversal may not go that easily, and they may spend a lot of time in the hospital with complications from that reversal. And unfortunately, if that connection comes apart, they will end up with an ileostomy or colostomy again. And in that situation, it may end up being permanent. So they may go through this very prolonged hospital stay and just have that unfortunate result. But, when patients want it, I respect their decision, but I also say, give it some time and see how you are with ileostomy or colostomy, and see if you really, really want to have it reversed. Like, what are the limitations to your life currently imposed by your stoma, and can you overcome those?
Thank you.
Sorry, I wanted to squeeze my question in here, and Patty said I could, even though she's standing there eyeballing me. I'll just I was watching Netflix. I was watching a stand-up comedy show the other day, and colostomy was the punchline of the guy's joke. And as an ET nurse or an ostomy nurse, I felt really sad about that. This is a question for you, I guess. Do you find public perception is changing about ostomies in general, and what do you think still needs to be done?
Yeah, so I know a lot of ostomy advocates. Many of them are friends of mine. And anytime the media gets something wrong about ostomies, we're on it. With something like a comedy special, there's kind of a gray area there, because I know with a lot of comedy, it can be very offensive to some, but that's in the name of comedy. So I don't know. I don't think that's something that most of us will go after. It'll just be like, well, that's in bad taste or something like that. But definitely when it's in the media, we try to make those corrections. We try to let the editor or whoever know about that. And we see this a lot with inflammatory bowel disease, where they get the whole thing wrong and they call it like irritable bowel disease, or they confuse it with IBS, and it's just like, it's totally wrong. But when it comes to ostomies, I don't run into it too often in the media, because a lot of the times they'll be interviewing someone who has an ostomy and they know enough to say, yeah, you can't say it that, or you can't say this. Because a lot of the time it's like this blanket statement, like the person has a colostomy, as like that applies to everything. And it's like, well, no, that's one type of ostomy, but it's not all types. So that's something we tend to try to correct. But as far as public perception goes, I think we still have a long way to go. I still think that not enough of the public understands exactly why someone might have an ostomy or what that means. I think we still have this idea like anybody with an ostomy is going to smell. That's not true. In fact, if you're using the right accessories and supplies, you probably smell a lot less even when you're going to the bathroom than someone who doesn't have an ostomy. I'll make that a point. Which is something to be proud of. But yeah, there's always a stigma that needs to be corrected, and I think that we still have a long way to go. But with social media, with the fact that we can reach so many people so very quickly and share good information, I think that we're going to reach the end of the ignorance, I think, of the public and media in general pretty soon. So.